being accepted by general, not these key opinion leaders you will see on the screen today or others, but generally the average practice, or have you put this to them or yet, or have you not given to them?
No, sir, we have launched it, sir, and we have launched it to across 400 surgeons.
We are live now.
Okay.
Okay, good.
Will I go off?
Right.
Just wait a few more seconds, sir. Please, sir, you can start your program, sir. Thank you so much.
Right. Good morning, everyone. I apologize for the delay in the transmission problems. I think we realized that the cataract surgery, which has become a refractive surgery for a few years, is very good and it's a good tool, but that's not enough, I understand. What we really want is to make the patient happy. And one way you can make happy is either charge them nothing or charge to their expectation, but that's a different point. But the best thing we can do as a clinician, as a surgeon, as a team, is to give them a quality of vision. And that quality of vision means many things. But one of the important things of value and has a meaningful outcome is the extended range of vision, maintaining that quality of vision in whatever way you can. Therefore, correcting not only the ametropic defocus, but astigmatic defocus as well. And we are very fortunate that the leading companies like Alcon, J&J, Zeiss, and many others are researching and bringing out lenses every few months, I would say, for the benefit of us and the patient. So I think today we have an expertise here amongst the faculty here, and we start because the time is not very much here. So we start with the first presentation with Dr. Samresh Srivastava and advanced preoperative diagnostic, how much is enough? Samresh, if you can restrict to 10 minutes or 12 at the maximum, please.
Sure, I'll try to keep it in time. Again, thanks a lot to Aios and the faculty for inviting me for this talk on advanced diagnostics. Just a second. Yeah. So we need to understand before we start the talk, and whether, number one, is there a special need for any refractive cataract surgery at this point in time? How to go about it? And does it enhance our practices in our day-to-day clinical scenario? I'm going to be just discussing the diagnostics we use in our clinic routinely and nothing more than that. So in our clinic, we tend to have a dedicated team for a preoperative workup, which obviously consists of an optometrist, a technician, counselor, apart from the operating surgeon or a doctor who can explain all the same to the patient. But more importantly, we decide to dedicate a different time slot for a preoperative workup, which essentially means we call these patients mostly in the lean time of the day, which is the afternoon, where the entire team is dedicated to delivering the right outcomes, the right time frame, and also not having a rush up with the patient at that point. Like always, I think most clinicians would do, it's best to evaluate both the eyes at the same time, visual acuity, and evaluate not only the visual acuity, but all the parameters for both the eyes together at the same time. Now, in the industry, we realize that there are so many diagnostics, and all trade fairs are completely full of newer machines. So it lands up to us to understand what works best for us in a clinical practice, and not to just go by other people's assessments of different diagnostics. So the first thing that we look at in our clinic, which is I think sometimes underrated but extremely important, is assessment of dry eyes, because that's the first refracting surface of the eye. Because if you don't get that right, anything you do inside the eye is not going to do any good, because the light's already started to scatter. I mean, initially it used to be tear film breakup and Shermer's, but we don't do that anymore in our clinic because of paucity of time, and also it's a little more invasive. But what I've learned the hard way is to look at the lid margins in the tear film under lid morphology, which I neglected for so many years and burned my fingers, because these were the patients that were unhappy despite a good surgery, because the problem was somewhere else and that was causing a dry eye in their eyes. So again, apart from the potential concerns of delayed wound healing, infection, and obviously delayed rehabilitation, there is a big concern of an unreliable biometry with the dry eye. And again, it's easy to understand that if you get this right, that the tear film is the refracting surface of the eye, the first refracting surface of the eye, you understand that an irregular tear film will obviously add to not only irregularity in the vision, but also irregularity in measurements. So this patient, if you look at, the patient came to our clinic and somebody has done an aberrometry. So this is just a topography showing a high astigmatism, and you can make out distorted Myers, which are not visible actually on data. But the moment you treat this patient with a lubricant eye drop, as you see over here, let the tear film stabilize for 10 minutes and repeat the topography, almost nearly the astigmatism disappears, showing you how important the tear film is. But not only that, it also boils down into IOL power calculation. So when we calculated the patient's IOL power, we were getting a 20 diopter with the previous run of diagnostics. But the moment we lubricated the patient's eyeball and waited for 10 minutes, the biometry dropped by 1 diopter because the K readings changed. And if we were to implant a lens based on this assessment, which was the initial assessment, because the technician did not pick it up and it was picked up later by the doctor, the patient would have been landed with the biometric surprise of 1 diopter, which would have been very embarrassing. So it's very important to get the tear film right. And for this, very important, look at the Myers of your topography that you're doing, but also look at the tear film breakup time. Now, again, it's very difficult to do it clinical scenario. I've used with the help of Dr. Himanshu Matalia, who exposed me to it, that's in tear film. But also newer topographies also have something very interesting called meibomian gland function. These are the dedicated meibomian gland machines that are there in many centers, some of the really good centers, including Narayan which give you a very objective assessment of the lipid function of the eye. But even if you're buying a simple topographer, and so these newer topography machines do have lipid analysis. And so it's very important that when you look at these machines, don't only pick up a topographer for its topography, but see what value or what benefit it adds to your clinic. Again, AutoRef, one more way of looking at meibomian glands, but doesn't quantify. So it's not really something that you can quantify. Moving on from the tear film to the cornea, anterior corneal curvature has always been of paramount importance, but now posterior corneal elevation, posterior corneal curvature is starting to catch up more and more, because we've realized that posterior cornea plays a very important role in calculating the IOL powers. Scheimpflug is a way of measuring the posterior cornea, and now OCT-based topographers are coming. So this is the anterior cornea, which we've always measured with a placido topographer or with a manual keratometry. And that's the posterior cornea, which we had missed out for so many years. And over the last decade, a lot of knowledge has been generated and a lot of understanding of posterior cornea has turned up. Just to show you a topography map from Scheimpflug imaging, shows you the pachymetry, which is very good because it tells you the overall picture of the cornea, but it also gives you the anterior and posterior keratometry readings so that you can make out if there is anything happening on the posterior cornea. Also, there is a lot of data available now. One needs to decipher this data based on their preferences, but I would always look at the anterior and posterior cornea K readings just to understand whether the posterior cornea follows the anterior cornea or whether something is happening at the back. It has been shown that residual astigmatism can be reduced by considering posterior cornea. So biometric surprises or toric surprises that do turn up sometimes could be attributable to the posterior cornea, which was not factored in previous IOL power calculations. But the good news is that 90%, almost most of the eyes will be okay if you don't do a posterior corneal estimation. And that's because anterior cornea generally tends to compensate for it, and newer IOL power formulas also tend to compensate for that. Again, for us, corneal astigmatism is one of the best clincher in diagnosis. So this is just to show you that even if you do a simple test like a manual K, do it right. If you do an immersion biometry, make sure that you're aligned to the patient's visual axis. Shift from contact to immersion biometry because there is a fixation target. But very importantly, if you can, and this is the right time to upgrade, shift to an optical biometry. Optical biometry or an OCT biometry or a Fourier domain, whatever is new, if you have now not shifted to any of these biometers, I think it would be a time is appropriate because the market is right and the patients do want better visual correction. It's important because this has distance fixation and the patient can fixate on the visual axis, giving you very good measurements with the visual axis. Newer advancements into topography, into biometries are swept source OCT. We have experience with the TOMI, which is at our Ahmedabad center. We decided to compare these two different principles, the OCT versus the optical biometry. And we found out that with the lens star, which is our optical biometer, we were able to get it in almost about 90% of the eyes. But in TOMI, almost all eyes, just short of fully mature blown cataracts, we were able to get axial length measurements. So which goes on to show both are good, but maybe OCT biometers have a little more penetrability, a little less number of patients sitting in and undergoing contact or immersion biometry. When we look at formula for IOL power calculations, I think our go-to formula has been for the last few years, a Barrett Universal 2 formula. We've also looked at the Hill RBF formula, but because the Barrett formula is very well incorporated into the newer machines and it's extremely predictable, we tend to rely very heavily on that. We published this from our team in British Journal of Ophthalmology in 2020, where we compared the IOL calculation methods after LASIK and radial keratotomy, where we had no idea of what the prior refractive data was. This is how we use the calculator from the ASCRS, which has all formulas. This is available for free for anyone who wants to do a post-refractive surgery IOL calculation or an RK patient. This formula is available for us for free. And so is a Barrett True K formula, which is also available in the APS-CRS website for free for everyone to use. And we found out that in LASIK, although all formula did very well, highest number of patients within a half a diopter residual were with the Barrett True K method and also with the Sharma's formula. Good part, like I said, with the neo formulas is they come integrated into your biometer. So when you get a biometric printout, you also get the access and you get a visual representation of when you have to put the IOL, which I think has reduced the workload significantly and made life really easy for us. And it makes data entry errors almost nearly impossible. Shifting gears from role of topography to aberrometry. Now, aberrometry is a gray zone when not everybody would want to invest in a machine like this. So I'm just going to be discussing based on my experience with the ray tracing aberrometer, which is the eye trace. It gives you a lot of data. Because it has a topography, it gives you a corneal profile. And because it has a ray tracing aberrometer, it gives you an internal profile of the eye, which essentially would mean the internal optics of the eye and in most likelihood, the lens of the eye. I'm going to skip out of this in the interest of time, just to show you a few examples on how it helps. So here's a 47-year-old female who comes to us with a 6x6 vision with the distinct complaint of being unable to drive at night. Mesopic pupil shows it to be fairly okay, but when you dilate, you can make out that there's a cataract developing at the extreme periphery. Now, this should not cause a problem in mesopic vision. So we run the patient through an aberrometry, and you can make out that there is a huge aberration profile of a spherical aberration, which is turning in. A spherical aberration profile in the optics of an eye with a pristine cornea indicates that something's going wrong with the lens. So clearly, when we put the patient on a mesopic vision, we realize that this is what the patient sees in the mesopic semi-dilated pupil state. But the moment we'll turn on the lights of our clinic, we can make out by analysis that the pupil becomes small and you have a pinhole effect and the patient is 6x6. And this is where we are assessing the patient, and that's where the patient's complaints are. Pentagram gives you a very good assessment of a nuclear sclerosis. So this patient was obviously developing a nuclear sclerosis, which was not being picked up on slit lamp. We had an initial series with Dr. Rohit in Naranathale, where we actually used to call it Zernike cataract, but now there are fancy terms for it also. So you can pick up outliers like this. Outliers like patients who wanting cataract surgery and need toric IOLs can also be picked up. So this is very interesting to show that this patient shows no astigmatism on an entire eye profile, but there is a corneal astigmatism which is very clearly visible even on topography, which is completely balanced off by the internal optics of the eye or the lens, which is giving rise to a no astigmatic profile in the patient's refraction. Now, if you were to tell the patient to get a toric IOL, most patients will not agree because they think they don't have a cylindrical number. But showing them good diagnostics like this will maybe help you in picking up these patients and explaining them that they're in desperate need for getting good IOL, toric IOLs. I'm just going to move on out of this to more relevant point just to save on time. So it's very important as cataract surgeons that we just don't look at the cataract alone, but also pay attention to the posterior segment of the eye. So nothing beats a good indirect ophthalmoscopy and a good retinal evaluation. But I think nothing also beats an OCT in today's date and time, and particularly if you're targeting emmetropia and targeting premium IOL practice. So again, our group under the guidance of Dr. Sudhalkar published a very interesting publication where we did a prospective observational case series of patients whose one eye was undergoing a nuclear sclerosis or PSC cataract and had no history of any other comorbidities, retinal or systemic. These eyes were subjected to an OCT and it was independently experienced and seen by an experienced retinal surgeon, and the surgeon was masked to the OCT finding. So the retinal surgeon did not know what the OCT picked up, and this was a large number of eyes, about 220 eyes, all age-related cataracts, and no systemic history, like I said. And the amount of diseases that we picked up, subtle diseases like epiretinal membrane, RP irregularity, was quite alarming. So again, in a normal-looking fundus, an epiretinal membrane or a breach or a irregular fovea with a lamellar macular hole, RP irregularities, which can give rise to subtle problems, retromacular tractions, foveal thinning, and so on and so forth. And these were the patients that were not picked up by clinical assessment. So it goes on to show that it's extremely important to pick up patients and use OCT as a cataract surgery tool and a refractive surgery tool as well. But at the end, it's the art and science of evaluation. And so no matter what diagnostics you use, please spend enough chair time with the patient to first understand the diagnostics and then to explain to them so that they can make intelligent decisions, not only based on their finances, but also based on their lifestyle requirements. Because once they make this decision, it's going to stay with them for life. Thank you.
Thank you, Samresh. Wonderful. In such a short time, you covered many, many important things. Before I comment, I would value Dr. Bala's one or two comments on the value of preoperative diagnostics or whatever his preference is. Dr. Bala, please.
I thank you very much, Dr. Vasavada, and thank you for inviting me to talk here. I think, as usual, Samresh's talk is always very pithy, and you get a lot of information from very brief talk. One of the most important things Samresh was talking about was the dry eye situation. And I think one I would add as a comment, even though you've put lubricants and you've gotten the correct IOL power, it is highly likely the patient's not going to be compliant with dry eye treatment and is possibly going to be unhappy afterwards because they're going to still be dry, and that astigmatism induced by the dry eye is going to show up. So it's very important to actually explain and counsel them that they have a problem and it's not your surgery.
Excellent. I think what it means is that continue to rely on your preoperative diagnosis and treat it, counsel them and keep treating it. We had a similar active lady who was very unhappy with the West Barker correcting IOL, and particularly at night time crossing the roads. And then when we treated a dry eye, she was happy, no halos, no glare, nothing. So Dr. Bala pointed out so important point that you must continue in the post-operative period, your treatment, your talking, counseling. But what I learned is that these preoperative workups, however expensive it may appear, has definitely a scientific value. But I also learned from this biometric example Samresh gave that you can use this tool or diagrams to counsel them properly, that although you're not wearing cylindrical glasses all your life, you'll need today because whatever the cancellation. So I think it's a very good counseling tool also. So it may be enough today for you, but stretch your limit and keep this information that we learned today. So thank you both of you very much. So we move on now to the very other important topics of extended range of vision IOLs. So Dr. Bala is going to share that with us.
Zoom, share screen. There we are, share. Hello, everyone. My name is Chandrabala. I'm an ophthalmologist in Sydney. If at any point you can't hear me, if somebody could let me know, because it's a bit hard to do it online. I am a consultant for Alcon, J&J, Hoya. I'm going to share with you our experience with Vivity as an extended depth of focus lens. As you're aware, there are many IOLs out there: accommodative, refractive, diffractive, pinhole IOLs, and the latest kid on the block is, of course, the wavefront shaping technology introduced by Alcon, which manages to shift and stretch the wavefront in the central 2 millimeters of the IOL. the concept extends to this idea of a light tunnel in the middle. A monofocal IOL has good distance vision, but tapers off towards the intermediate. Diffractive IOLs tend to have peaks and troughs, whereas by having this new wavefront shaping technology, you're able to create a long, thin pencil of extended depth of focus, which allows you to see far and intermediate quite well, and sometimes even a fraction of near. Keeping that pencil tight and narrow means that you don't have that much scatter outside the intended focal point, and therefore you get less blur, halo, and glare with this lens. I had the pleasure of being the chief investigator for the OUS study of Alcons, and the lens is a wonderful lens. It is based on the same platform as SN60 wavefront, so most people are completely comfortable with the lens. And it's a non-diffractive technology, which has also changed the way people have been thinking about it, with a central 2 millimeter annulus and a 1.1 micron elevation from the background. So it's not much, but for what it does have, it punches well above its weight. This is the defocus curve, and I'll draw your attention to the fact that it's fairly flat from 0 to 1.5 diopters. And so it, given its vision at all points during that range is better than 6.9, people get excellent quality of vision as is expected from an EDOF within that range. Now, there are two types of doctors out there. There are the non-refractive doctors and the refractive doctors. The non-refractive doctors who have just come to this concept of presbyopia correcting IOLs have heard a long story of diffractive IOLs and glare and halo. And apart from the price point being an issue, it is also an issue of once you've implanted, you don't want to add more chair time to your life. Often the non-refractive doctors don't have such pristine patients with pristine eyes, and they want to consider monovision, mini monovision. And so the cohort of patients is different from a refractive doctor who tends to get more pristine eyes, and they are sitting in the world of trifocal IOLs. And for them, it's a different set of challenges as to why, say, they should put a EDOF lens and what to do in post-myopic cases and in very high myopes. So we have a whole lot of both types of doctors in our practice. There are 12 doctors who are operating. Of those, only the 2 who are circled there are refractive doctors. We as a group have been doing presbyopia correcting IOLs for a decade, but only 2 doctors have ever done them in the form of trifocal IOLs. The rest have never touched a trifocal IOL or a bifocal IOL. And that's an important point to remember, because in 2019, the 2 of us were doing 8% of the whole lot was panoptics. 92% was non-panoptic cases, where monofocal lenses only. In 2020, when Vivity became commercially available, that number gradually picked up. And by 2021, half the cases that we were doing, which were about 464 Vivity lenses were implanted. And that too, that number was small because the range was limited. The lens suddenly became very popular with every doctor, refractive or otherwise. And on average, everybody was getting around 6.6 with N8 for 50 centimeters. And if there is a take-home message in there, it is this change in surgeon behavior. And the second take-home message is that 6.6 N8 shows you that you've actually nailed the lens in the correct place for that particular eye. I just want to quickly play a 1-minute video.
I'm an ophthalmologist and specifically a cataract surgeon and a medical retina consultant in a group called First Eyes, which has multiple practices in New South Wales and Canada. I was shocked. I wasn't expecting to develop cataract at this age, but once I realised that that was the problem, it was really clear that it was impacting on my ability to see. I was cleaning the operating microscope constantly, feeling as if it was blurred, but it wasn't my microscope, it was my eye. So the colleague who did the surgery for me, Dr. Chandrabala, is a refractive colleague, and he does use a lot of multifocal intraocular lenses that people like Dr. Zimmerman. Reasoning being that we do a lot of very close work, a lot of reading, but I was very put off about having one of those lenses because I'm aware that some patients are like halos and glare afterwards. We spend an awful lot of time in the dark room with bright lights. those multifocal lenses sometimes are problematic, for example, night driving. A lot of my work is in very similar lighting conditions. So I was absolutely adamant that I really wanted to avoid because of those light side effects, and that what I was most interested in was clarity of vision. So that moved the discussion onto extended focus lenses, and that was much more appealing to me, having looked at the data. So I made the decision to go ahead with surgery very quickly, and in fact have the operation a week later. It was a little odd dedication.
So Angela had a posterior subcapsular cataract, and if you look at her numbers to the left, you can see she has a little bit of monovision, about 1 diopter. And as Angela mentioned, for most doctors and lawyers, I really encourage them to go for a trifocal IOL because of the amount of reading they do. But Angela was completely adamant. She was a medical retina specialist, and she would not accept that. So the choice was to go plano or to go slightly minus so that she could get some reading. Slightly minus because Vivity would perform. You could take advantage of the flat defocus curve and get more near vision for her. Sorry, I'm trying to go to the next slide. She had uncomplicated cataract surgery. We tried a 22.5, aimed for -1/4. As I said, we just wanted to get a little bit more near. And interestingly enough, she got 6.4.8 and N5 for near, which was quite a surprise. We waited for a month to see if that would change, but luckily for me, she got an excellent result. She was between eyes, it took us about 4 to 6 weeks to operate. So during that time, she was driving. She would drive 400 kilometers to a couple of the clinics, and she would report to me that she could see one halo, and that never seemed to bother her with her night driving. Then the question arose, what to do with the second eye? Do I aim for -1, or do I, again, consider mix and match, or do we go for plano? So I demonstrated what it would look like, and Angela had never had excellent distance vision. So she chose to go right ahead with distance Vivity again for the left eye. I won't play the video. She did very well, and binocularly she sees 6.3.8 with the Vivity IOL. And this meant that suddenly all the doctors in our practice became very comfortable with the idea of implanting an EDOF lens like Vivity. And so came the new boom, and people like Angela herself was comfortable implanting it into other people's eyes. And so this is the case of an 83-year-old patient who does not have a pristine eye, has excellent, had 6/12 vision. The retinal structure, you can see that the photoreceptor layers are still quite intact. There are drusen underneath, but we felt that it was still worthwhile. The patient got 6.9 and N8 for near. And so that gives you a lot more functional vision, at least for the moment, till the macula deteriorates. Even in glaucoma, if you have, this is a patient who had a Dorsal Hemorrhage, has had a field loss in the left eye. The patient is -2.5 in one eye and -4.5 in the other eye. And so we took opportunity of the fact that the patient has an isometropia. And again, excellent vision, 6.6 and N8 for near in the contralateral eye, where we left her slightly myopic. Diabetic retinopathy, we've had extensive discussion with the patient and consented them, because you can see the whole page of consent form there. And again, the patient does very well with even in proliferative diabetic retinopathy cases. In refractive surgery, of course, it's a different ball game. The counseling process is much longer. You have to spend more time to explain what can be expected and what cannot be expected. Here's a patient who is -3 myope. And a patient like this, I would always be reluctant to do a trifocal IOL, largely because I would aim for distance, and the near vision was never as good as a -3 myope would expect. So in this case, Vivity was a much better choice. We aimed for -1.5. This way, at least the unaided vision picked up from 645 and 660 to 612, and the patient is still able to see very well for near. And so you can customize the treatment depending upon what the patient actually needs and what the patient wants. We've also done mix and match with UltraCert. This patient had an UltraCert in one eye before and was -1.5 in the other eye. Eventually, they developed a cataract in the contralateral eye, and we decided to do a Vivity on the other side, and the patient is seeing 6.9. We left this patient slightly myopic and can get N6 for near. And this is one of the beauty of the Vivity lens is if you do have anisometropia and you want to try mini monovision, and if you choose -1/2 asymmetry between the two eyes, you don't have to really worry about ocular dominance with this lens. Post-refractive surgery, you will remember the EDOF, the depth of focus, the defocus curve was very flat. Here's a patient who didn't know whether she had hyperopic or myopic LASIK, but the pentacam showed that was most likely a hyperopic LASIK. This is a wonderful lens to take advantage of the long landing platform. And so even if you make a slight error and you aim slightly hyperopic or slightly myopic, the distance vision often tends to be excellent. And we managed to get, again, N8 for this patient with 6.6 and 6.9 for the right and left eyes respectively. We know that aberrated corneas are not somewhere where you would put a trifocal IOL or, because the amount of scatter that Samresh mentioned, the scatter starts at the cornea. Here's a patient who had a large scar over the cornea. I peeled it off. 3 months later, we rechecked the topography. Things had changed dramatically. The higher order aberration in the cornea was still at 0.174. The Q value was at 0.3. Remembering Vivity is an aspheric IOL, most of the time we would have been comfortable with 0.5 as our upper end of higher order aberrations. But we did one eye and then the second eye, and he again was 6.6 and has been spectacle free for the first time in 60 years. As I mentioned to you before, the Vivity is based on the SN60 platform, and only the central 2 millimeters of it is different. Here is a patient who had a Vivity implanted, and at that time, during surgery, there were some issues with the zonules, and unfortunately, the patient didn't receive a capsular tension ring at that time. By the time I saw the patient, he had lost his near vision. At best, he was at any one point seeing N14. He was seeing double, not from the Vivity itself, but the fact that he had a refractive error. And I was able to get him to 6.6 with a subjective refraction. I then put a with ring segment, tied it up, and he again reached 6.75 with a small correction, and suddenly his reading returned. So even if the lens is defocused, you're not going to have the same issues as a trifocal or a diffractive IOL, where you get a whole lot more glare and halo because of the defocus, as well as because of the external rings on top. So my tips, if people are wanting to start on Vivity, is first, expect 6.6 and N8 at around 40-50 centimeters. They expect to advise them to wear about +150 at nighttime, especially if they want to read in bed. If the far is 6.6 and the near you did not hit N8 and it is less, then it's likely you have had a hyperopic outcome and you would repeat a subjective refraction pushing plus. If you're after monovision, an anisometropy of 0.5 is easily acceptable. Ocular dominance in that case is not important, and I can assure you 2/3 of your patients will be spectacle free for all tasks. If you aim both eyes for far, you can expect about 1/3 will be spectacle free for most tasks. The lens is safe in AMD. If retinal thickness and photoreceptor architecture is good, we haven't done a full contrast sensitivity study, but if those are good, then I think your patient will still benefit from a Vivity. Contrast sensitivity was not a problem in the original trial, and therefore we felt quite confident in using in glaucoma cases. The tip for refractive surgery, if you want to secure a endpoint, you should take advantage of the Vivity's flat defocus curve, because that way you will, more often than not, most likely you will somehow get a good unaided distance vision. If you do have decentration, don't worry, it'll automatically behave like a monofocal lens, and you can deal with it the same way you would deal with a monofocal lens. Thank you very much.
Thank you, Dr. Bala. Wonderful, and some very good news that VVT not only gives additional extended range of vision in intermediate and some reading, but also is compatible with some degree of comorbidity. That's nice to know. I would value a question or comment from Dr. Samresh and Dr. Sandeep. One question or comment, please.
So, Dr. Bala, it was a very good talk. The other message that I took very well was, there's a lot of wiggle space with the Vivity. So even if you target a little myopia or hypermetropia, the patient is still more or less okay. I wanted to know whether the lens, when you're targeting an emetropia, with the advised A constant from the company, are you having a hyperopic or a myopic tendency, or is it bang on for you?
So we are using an A constant of 119.1. Some of my colleagues initially went to 119.2. The A constant shift of 0.1 doesn't really change the middle of the group, as you know. It was just that sometimes they would then choose a slightly myopic lens and end up more myopic than they expected.
Correct.
So the first step, they would have gone to a minus 0.4 or 0.5, and suddenly the distance vision is gone. And this, in a market where in Sydney, it's almost like San Francisco, it's a very, very refractive market that then causes a lot of issues for me.
Okay. Thank you.
Okay. Sandeep, you have any comment or a question?
Yeah, I think that was a wonderful talk, Chandra, as usual.
Thank you.
Vivity is an excellent lens. I've just taken to it and I've implanted about 59 so far. The interesting thing I'd like to comment is that in the last couple of months, my Vivities have started going above the panoptics. So I think it's a great lens. And the best part about this lens, as you so eloquently described, is it doesn't get affected by some comorbidities in the eye. And so we feel more, more confident of using these patients in the kind of scenarios that you spoke about. So I hope to gain more experience. And our experience is nowhere like yours. You have a massive number of.
Thank you. The lens is very much a plug and play. And I think Vivity has opened the door for the EDOF market completely. And although it is currently the dominant or will be the dominant player, soon there will be a lot of competition for it from other companies as well, which are also seriously looking at EDOF lenses. And I think that's where the prices issue will also get addressed.
Well, I think it's a very wishful thinking that it will come down. I doubt that, knowing this person. but what I learned today is very good. But only thing is that, and this is my experience as well, that if you are ametropic, if you are not targeting the refraction from the comment, patients will have a blurred vision. And because unlike Australia, the patients pay here, they may not take that well. So that's an issue. We need to counsel them properly. More chair time than panoptics, because they're paying, and if you do not make them emetropic or target at 0.5 minus, they will not be very happy because of the pricing and because the money they have to pay themselves. So that's something demands a precise and precision in preoperative workup and understanding. So that basics still remain very fundamental, that pay your enough time, chair time, and investigate preoperatively so that you are likely to hit the targeted refraction better.
I think if doctors are unified and you have a refractive colleague and you can set up a methodology, like Dr. Vasavada, you were saying the other day, you have retina colleagues come and operate with you. If you have, similarly, you can have a collaboration with a refractive colleague, then if there is a need for a touch-up and the patient is bitterly unhappy, then you could perhaps share that care with that other doctor.
I agree. It's a very nice suggestion. Thank you. So I think now, thank you so much. Then we now move on to the other important topic, and Sandeep just mentioned that like Sydney and like San Francisco, Mumbai practice is also catching up to these two cities. So Sandeep, tell us.
Is my slide visible?
Yes, yes.
Okay. So top tips from experience in trifocal IOLs, a little limited as compared to what we heard from Chandrabala. I may have implanted about 700 odd trifocals so far, out of which 403 have been panoptics, the lens that we are talking about. Now, we start on a slightly defensive note because unlike Vivity, which does well in all kinds of eyes, you have to be very choosy and picky about trifocals. When these Vivity lenses were not around, we used to implant them quite regularly in all patients who desired some kind of presbyopia correction. But there are some issues with trifocals, basically because they split light into 3 focal points. There is a 12% loss of light even in the best in class, and therefore it impacts scotopic contrast sensitivity. There is reduced nighttime visual disturbances as compared to other trifocals, but they are not eliminated completely. And one of the main difficulties that patients face is that they have some difficulty in reading in dim light, especially for certain patients with suboptimal ocular health, either due to ocular surface disease or those who have higher order aberrations. However, having said that, there is a distinct set of patients who demand to read without glasses. And the trifocals just fulfills that need because it just gives you that. And not only that, it gives you a continuous range of vision from 40 to 80 centimeters, which helps patients to enjoy most of the tasks that they like doing and where they would like to do these tasks without the aid of glasses. So what is a tip to success with trifocal? I mean, this depends on 5 factors, and I'm afraid a lot of my talk will be a little repetition of what Samresh spoke so eloquently about. But the goal remains here. You have to select your patients carefully. You have to do an accurate biometry. You have to do a complete thorough workup. You need to give good patient counseling, and you need to have a precise surgical execution. Now, the first and most important thing that you must remember with a trifocal is that you have to touch emetropia in both eyes. I do not do a fudge factor like I would do in a pivoti, because the performance of this lens, which is basically designed to give emetropia for distance, intermediate, and near, depends on achieving emetropia for distance. So you need to have excellent biometry, and there are enough papers to show that a residual refractive error can impact the visual performance of this lens. The second most important thing is that you have to address even small quantities of astigmatism. If someone tells me that the patient is only 0.3 diopters of astigmatism, that is not enough. A 0.3 diopter of astigmatism with the rule is probably enough, but a 0.3 diopter of astigmatism against the rule probably needs a management with a toric IOL. Need to look at the lids very carefully, as Samresh said. It would be very nice if a trifocal patient or a patient opting for a trifocal has lid glands like this. But when someone has something like this or like this, then of course these patients need kind of management. And it can be seen by examples over here. This is a patient who came to us asking for a trifocal IOL, and we looked at the topography. We are not very happy with the astigmatism that is shown here. And you can see on the ocular surface also, there was some hyperemia. And see the result after treatment. And this patient was treated for meibomian gland dysfunction with tear lubricants and a little bit of corticosteroid for about 10 days. When the patient came 6 weeks later, the topography was pristine, and we were able to assess the astigmatism very completely. So here is where I'd break in when Samresh said about putting the drop and getting the improvement. But if you need to take this patient further, and as Dr. Chandrabala said, these patients are not likely to follow up in the future, it's important to give them a break for 4 to 6 weeks. You must be able to counsel the patients to wait for that time and get the treatment done. And here is the other eye of another patient, again, who had dry eye disease, was not showing very good Myers or the topography axis. And this is the outcome of treatment. Beautiful, against the rule astigmatism, classical dumbbells, patient did very well with the trifocal. Of course, we would like all our patients to have a kind of a nice, good prolate cornea with minimal higher order aberrations. But that's not always the case. Sometimes you have an oblate cornea with extremely higher order aberrations, and we have to turn these lenses, these patients away from a trifocal. What is the role of tomographers? The main thing that the tomographer shows is the amount of posterior corneal astigmatism. Here is the case of against the rule astigmatism. But if you look at most posterior corneal astigmatism, it's about 0.3 diopters. And 0.3 diopters does very well because that's the assumption by Barrett in most of his formulas. But once in a while, you get a patient with a higher posterior corneal astigmatism or a lower posterior corneal astigmatism. Now you'd ask me, why is this important? This is important because if you know that Barrett normally calculates 0.3, and suppose you have a 0.5 or a 0.7, you may need to switch to a higher grade of the toricity. So T3 could become a T4, or in the reverse, the T3 could become a T2 if you have just 0.1 diopter astigmatism. Now, all this talk of higher order aberrations and its impact on the visual performance, remember, in those patients who are very keen to get a trifocal, it's very important to look at the pupil size. So this is a patient with a normal size pupil, which is about 5.1 in mesopic conditions. But sometimes you get a patient with a mesopic pupil of 3.17. Now this patient would have very minimal higher order aberrations if you calculate the aberration for this kind of a pupil. And so a patient who may seem undesirable otherwise for a trifocal can suddenly be a good candidate for a trifocal. Or a patient like this who has a higher than a 6 millimeter pupil, and this is a condition in a mesopic pupil, may not be the best candidate if those higher order aberrations are already measured by your measuring devices. Again, as Samresh said, the OCT plays an important role, not to pick out cases like this, which is a very manifest ERN and which could be picked up even on the clinical examination, but a subtle finding, such as a patient who has got a pressure of 18, and when you do his OCT, don't only do his macula, look at his disc also. You might find a little bit of thinning or RNFL in the inferior quadrant. Do his field and you'll find that the patient already has early glaucoma. You could miss this out. Or a subtle diabetic macular edema, or a patient who has got a very small macular hole. Now, these are cases which can easily, as Samresh very easily said, very eloquently spoke about, that they can be easily missed out by even the retinal specialist. So when it comes to patient selection, the most important person out here is the patient himself. Typically, in any practice, you have about 20 to 30% of patients who may be opting for a multifocal IOL. Now, those who are motivated with realistic expectations are probably the ideal patients. But those who are motivated with very high expectations may not be the ideal patient, but it's a challenging patient. I like to take up on these patients because these are patients who refer me more patients. And of course, patients who are motivated, but they have unrealistic expectations or coexisting ocular pathologies, you need to shift them over to a toric or a monofocal IOL. So who are the patients who might select for my trifocals? These are patients who no longer desire to wear glasses because of their age and because of their functional and ocular requirements. These should be patients who expect good unaided near vision. They should be alert to the possibility that they need to get a bilateral implant done. And that's one important point I'd like to make out, that all trifocal patients should be counseled for early second implant. I normally don't like to keep a gap of more than 3 months, but of course, it varies from practice to practice. So who are the ideal patients? Those who are desirous of spectacle independence, especially for reading. Those who have got normalized except for cataract. And this is where I'd say that all my 3-lex patients, those patients who don't have significant cataract, are not good candidates, I've realized, for a trifocal. They're probably better off with the Vivity. Having said that, doesn't mean there would be occasionally a patient who demands to read without glasses. He needs to be counseled about the loss of contrast. And if he's still good enough and willing to accept that, you can put in a trifocal. These patients should have regular or no astigmatism. I need to have an accurate biometry. I feel uncomfortable if my patient I'm not able to assess on an optical biometry because of a mature or hypermature cataract. These patients should have a good, pristine topography with no previous refractive surgery, minimal higher order aberrations. They should be willing to tolerate some halos and a mild glare and willing for bilateral implantations. These are patients who are not so good candidates. Those who are demanding patients, those who are fearsome of reported nighttime visual disturbances, who are night drivers by profession, or who work in dimly lit environments. Be careful in patients who have significant dry eye disease and ocular surface disease, patients who are low myopes. These are patients who always had good vision without glasses and are unwilling to accept the fact that they need better light in order to read fine print. Patients who are emetropic and who do not have significant cataract. Remember, all patients typically would like to achieve emetropia for all distances, distance, intermediate, and near, and without nighttime visual disturbances. But it's not possible to satisfy all, and we need to explain to this patient, because sometimes once in a way this patient may turn around and say, after having implanted, do I still need to wear glasses? Okay, so you must be able to assess your patient. You must be able to judge your patient. I assess the patient from the moment he walks into my clinic, from the way he walks, whether he's wearing glasses, what's the thickness of his glasses, how he speaks, how he dresses, how he's, you need to smell the trifocal. You need to be able to tell that this patient is a good candidate, because a lot ultimately depends upon the personality. We have to match their expectations. Sometimes we have to modify their expectations, but in the end, we should be able to give them what they want or what the lens can perform. Remember, the lens is an art piece of physics. So it's going to behave the same every time on the optical bench, but each eye is different. And therefore, the visual performance in a certain eye with a certain pupil size could be different. So you cannot say that this lens of this company is better than this. This lens in which eye is what is important. The most important thing in all these cases is counseling the patient. You need to document in the clinical chart what you tell the patient, counsel them about the visual disturbances, counsel them about the reading distance. Tell them it takes full time. It takes time for full adaptation. Don't ever promise that you will not wear glasses again. And remember, of course, as Dr. Vasavada said, these people are paying out of their pocket. So obviously they expect much more. And so we need to modify their expectations. There's not much in surgical pearls because ultimately all of us are good cataract surgeons. All that we need to do is put the lens in safely. Remember, if possible, align the optical center along the visual axis and do not implant the trifocal in case of zonular integrity or significant vitreous loss. One small little thing over here, when you're doing your optical biometer, just have a look at your angle kappa. The X is 0.4. And if possible, you can try and align the optical center. Remember, the lens centers in the bag depending on the direction of the axis. So when you're looking at angle kappa, which is the horizontal meridian, it does well for patients who are getting a non-toric trifocal or patients who are with the rule astigmatism. Because this lens, you can nudge in this direction or in this direction. However, in cases of patients with against the rule astigmatism, it is not possible to do so. So what is the impact on our practice? We are now more confident than ever before while offering premium refractive cataract surgery to our patients. Approximately 20 to 25% of our patients are now opting for presbyopic correcting IOLs. By communicating clearly and openly with our patients, we are now able to retain their loyalty and adherence despite being asked to wait to ensure fitness of the ocular surface prior to surgery. Patients pre-counseled about expected visual outcomes are now the best ambassadors for our services. So the most important thing is that after all these years, we have earned the faith of our patients. It is important for us to keep that faith. Be open, tell the patients what to expect. And I think if you follow these simple pearls, you will have a successful presbyopic IOL practice. Thank you so much.
Excellent, Sandeep, as always. Your rich experience of using these advanced presbyopia correcting lenses, and every time I hear, I really pick up a point. I'll comment on that a little later, but I would value Naren's comments because he's been a prolific surgeon and he's at a center which is our premier center in India. So Naren, any comments on Sandeep's talk or any other thing that you want to make very briefly?
Thank you, sir. Thank you so much. Dr. Sandeep, a wonderful presentation as usual. I think I would totally agree. I mean, actually, the current generation of trifocal lenses are actually a fantastic. I mean, you know, the doctors have become more confident in implanting because when the generation of the multifocal IOLs, a lot of doctors had a lot of anxiety, and patients who had the lens in them, they regretted it. But with this current generation of trifocals, it does such a wonderful job. You don't need to worry at all. Just implant the lens. Tomorrow you'll do well. Obviously, you need to make sure the eye is suitable for it, and then you go for it. It is fantastic. I think in terms of EDOF lenses, like Dr. Bala said, I completely second all his words. I mean. It is you know, a lot of patients who can afford and really want it, and they couldn't because of many scenarios, be it retina issues or other issues. But the VVD lens has really opened up you know, the opportunity for them to have some kind of a you know, extended vision, which really helps them that, you know, even their computer vision or cooking and other the tasks what they do, they can achieve with this particular lens, definitely.
I think what I have learned, and I heard Dr. Bala also commenting on the same point, and I echo more or less same as you said earlier in some other meetings. At least we can tell the patients that, look, you have this comorbidity, and worst scenario in case of the achieving the targeted refraction would be that you will be seeing as good as you would have seen with monofocal. So although you are paying more for possible intermediate and reading, it won't degrade the original potential of vision that you would have got it with monofocal. So I hope that you will get some degree of intermediate reading, but that depends on the function of your comorbidity, how impactful is on the anatomically is this, but functionally we can't assess. So if we counsel them, we can make this patient accept, because surely they would perform as good or as bad as the monofocal in these comorbidity eyes otherwise. So I think this is a great potential, unlike trifocal and PanOptics and many other things. So that's very good. But what I liked about PanOptics are two things. One is that my chair time is not as much as with Vivity. Vivity, I really have to explain much more, I must say. I've never taken so much time earlier with any lens, but PanOptics is hardly any time. And also the continuous range of vision that it gives from 40 centimeter to 65 or whatever, really is something I never realized with the earlier multifocal lenses. I have tried in a very limited sense the Physiol IOL, which also is very good, but I found the PanOptics has less halos than this photopsia, and also they appreciate this continuous range a little better because of the distance of that reading from 60 to 70 or 80 or whatever. So I found these two features very useful for me to talk about to the patients. So if you have any other comments, do that. Otherwise, we move on to the next one. Anybody?
So just
anyone?
So
yes,
one,
yes.
I mean, something that what we found very funny or very interesting is actually when you compare the VVT lens to a monofocal lens, there are more chances of you achieving a 6/6 vision with the VVT as compared to monofocal because of the extended vision. It really, the hit rate is much more when compared to a monofocal lens.
Naren, I respect you very much, and you are one of the greatest guys. I disagree with that, I must say. But I find difficult to understand a VVT getting a better vision than a monofocal IQ, for example. But yeah, I mean, you are richer in experience, so I understand and I listen to you. But I keep in mind that, surely. Anybody else? Any comments? Any other comments or anything else?
Dr. Basavara, I would just say that, look, with the trifocals, the only problem is expectation is the mother of all frustration. And if you don't get that expectation down pat, this is where people often fall through. And so the fundamental thing I do, and I hope everybody, I mean, it's something I do anyway, is I get them to take their phone out of their bag. And I say, show me your phone. And I write down what size the WhatsApp font is, what size the SMS is, and what size Facebook font is. If the font is set at N14, I'm on a winning wicket. I cannot do wrong. If the font is at N8, I go, this is going to be difficult for you to see such a big jump, especially unaided font. And then I say, look, I'll get you to N8, but anything smaller is too small, and you will need to buy a plus 150 for that. So I never promise spectacle total independence. Magnifier, I don't even call it glasses. I say you need a magnifier, from the chemist, 150. And so that's how I know which of my patients is going to be happy and which one's not going to be happy.
I agree. Wonderful. Very good, useful. We'll keep in mind. Very nice. Thank you. I think we move on and we'll keep discussing at the end if you have the time. Chandra, it's your own another topic that you're talking. Well, Dr. Bala is going to leave after this presentation. So if anyone or anybody from the audience has any questions, please do that at that time. Thank you. Go ahead.
So this is an interesting topic about extending the range of vision of monofocal IOL design. It basically, I was asked to talk a little bit about monovision, which is something that we have started to do less and less. Obviously, monovision by definition is an attempt to use anisometropia to extend the range of vision of an individual. The amount of anisometropia you induce varies a lot. And the idea is to achieve some sort of pseudo accommodation in one eye. And that amount of pseudo accommodation is a little bit more complicated than what we often think of. It requires a certain amount of postoperative myopia, a depth of focus within that eye lens, an amount of meiosis, how much the patient squeezes their eyelids together, the spherical aberration of the system, and the corneal multimodality. So a composite of that leads to pseudo accommodation. Now, if you look at each lens, and this is a beautiful publication that is in Acta Ophthalmologica, which tries to model this. There have been lots of studies on monovision, but this actually tried to model it by looking at the fixation distance in meters and looking at the amount of defocus created by the lens. So if an object is at position F, the person is able to see to position D and back to P because of the depth of focus of the eye. And that depth of field, if you look at figure 2, which is to your right, there are two scenarios. A patient is -1/4, and they can see perfectly at 4 meters because they're -1/4. And then the vision is relatively flat for distance, and then it gets worse as you come towards -1. If the patient is -1.25, they see very well at 75 centimeters, so the blue line dips down to 0. And before that, there is a relative amount of blur. When the blur circle, for this sort of condition, before -0.75, the better, the line which has the smaller area under the curve dominates, and the summated amount then gives you the good conjoined, fused image from far to near. Now, that concept, if you actually do it in real life, say in the next image below, if you're a -1/4 in both eyes, you see very well for far, but around 2 meters onwards, it slowly starts dropping and the logma visual acuity drops off. This is a practical comparison of the mathematical model. And so if you did -1/4 in one eye and -1.25, obviously you extend that range. The point there being, with a -1.25 anisometropia or a difference of 1 to 1.25, you actually get a very flat profile all along. So the how much you do, how you optimally distribute your refraction, whether you choose -0.5, -3/4, -1.25, or some people even go as far as 2. If you were to look at the mathematical model, you would tend to favor -1.25 as your anisometropia. There is actually some mathematical logic behind it. And if you were to look at this defocus curve, which you've seen before, which is of SN60 wavefront and the vivity, the SN60 wavefront is in black. I've taken the liberty of obviously altering somebody else's data, which is Alcon's data. And sorry, I'm trying to move. If you go shift that SN60 wavefront so that it gives you the same amount of intermediate vision as vivity, let's say, vivity is quite good. Everybody seems to be happy. At 1.5, you're getting about in 60 centimeters, you're getting N8. I just shift that along. I have to shift it by about -0.75, a monofocal lens, to get that performance of vivity. I have to shift it further to get good near visual acuity. I have to shift the SN60 wavefront by 1.25. So you can see logically, when you get to 1.25, you actually see quite well. And do you really need to push it further? In my case, I am very happy with a difference of 1.25. Now, that pseudo accommodation, I've so far been talking about the refractive outcome. But pseudo accommodation is more than just the myopia that you induce in the IOL. There are a number of other factors, such as meiosis, depth of focus of the lens material, the asphericity, the lid squeezing, all these. And I want to share with you an interesting project we did, and it's been submitted for publication. This is a defocus curve of a panoptic lens. It's been flipped upside down. The orange line is a set text message size. Now, if you're between -1 and -3 and you want to see that, the blue area in the middle that area in between these two curves, is your reserve capacity. If you see more than the orange line, then you can see the orange line. That's the minimum vision you need. So that blue area is your reserve capacity. Now, we always think of defocus curves for the population. We don't think of the defocus curve for an individual. If you actually sit and measure for each individual and calculate the area under the curve, you find at the bottom, you will see two histograms. The one on the right is at 3 months, and it shows you that for each, the individual amount of area under the curve varies for the same lens, same model lens. This is best corrected defocus curve data. So it's not a refractive error issue. The same lens is performing differently and has a different area of under the curve. For some people, they just don't have the same reserve. For others, they have a lot of reserve. And this is a comparison between the Panoptics and the Zeiss AT-LISA trifocal. And so you suddenly get to realize that biology has more of an impact than just the power of the IOL you choose in terms of anisometropia. Anisometropia monovision is quite successful. It works about 80% of the time. Whether you think 80% is quite successful or not, and this is a lovely literature review that was published some time ago of monovision, whether you consider in this modern era, I suppose in Mumbai that would not be considered satisfactory, whereas in other parts of the world that might be more acceptable as an outcome. But even with that, there are disadvantages with monovision, and therefore there's a demand sort of to move away from that concept. The issues are still of glare and halo because of the anisometropia. You are creating a blur around, especially in mesopic low light conditions, you're creating a blur around the object. And that anisometropic suppression is, you can suppress it yourself, provided you are not too myopic on one eye. So if your anisometropia is a 1 1/4 or less, you can actually suppress that. Contrast sensitivity, when you look at an object with both eyes, your contrast is much better than if you have one in focus and one out of focus. And that contrast sensitivity dramatically deteriorates if your anisometropia is greater than 1 1/2. Stereo acuity is also affected when you have one eye for far and one eye for near. However, while the stereo acuity drops from 40 to anywhere from 40 to 200 and can vary from person to person, it is not enough to impact their activities of daily living significantly. So whilst you stay under 1 1/2 diopters, again, you're reasonably likely to get it right. The problem, of course, is that of ocular dominance. Which eye is the dominant eye? And they have a cataract, you can't tell. Right-handed people can be left dominant, such as myself. I'm strongly left dominant when it comes to my eye. I probably was a left-handed fellow, but my parents changed me to right-hand. So getting the dominant eye wrong is also an issue. Whilst in a group study situation, here the near eye was set to 1 1/2 to 2, distance eye was set to -1/4. You see they're very comparable. The first row of graphs tells you the uncorrected distance visual acuity. The uncorrected binocular distance visual acuity is poorer for the crossed eye group. And the near visual acuity is kind of neither here nor there. It's okay. But if you go to the second one, second set of graphs, the distal spectacle independence is slightly high, is quite high for distance and near for the crossed group. It might not be statistically significant because it's hard to apply some of these statistics, but in this case, especially for near, they were far more spectacle dependent. And if you go to the rightmost column, which is the postoperative satisfaction, there are people, 10% of the population thought they were worse off, 6% for distance, 6.5% for distance thought they were worse off. And one of the things people really don't like is being worse off all the time for distance. For near task, it's a slightly different matter. They have been trained to accept it. Also, the issue is of targeting -1.25. It is actually a little bit harder to get 1.25 as a target. It is easier, and studies have shown this, to actually target emetropia. The error rate for near is actually slightly harder. There have been other studies that have shown that there is no difference if you cross the two eyes, but practical experience tells us that it's different. Future of monovision versus bifocal PCIOLs. Now, we have talked about presbyopia correcting IOLs, and if you compare the bifocal of the past, such as the Hoya lens, then of course there was more of a comparison. But now you've heard from other speakers that, you know, the new trifocals are so much better that it is hard to justify going down towards a monofocal, towards monovision, where there is still a loss of stereopsis, which you don't get when you target both eyes for far. Now, in my practice, how do I select patients? I find it a difficult concept to explain one eye for far and one eye for near. I can explain it, but usually I get a shocking response from the patient, like they have never heard it before. However, if you're born with an isometropia, I think you should be smart enough to use that to your advantage. If they've had asymmetric nucleus sclerotic cataract and induced monovision on themselves and have had second sight later in life, again, it's a worthwhile concept to keep in, because they've gotten used to it. If they've been practicing in contact lens, of course I would do it. Commercial drivers, I never do it because they require good unaided vision for driving. And so again, that's a group that we don't do. How much anisometropia? Generally, I used to target 1.25. 0.75 to me was not really worth it unless you are an active desktop user, which is diminishing these days because everybody's got an iPhone or some sort of smartphone. But now around 0.5 to 0.6 has suddenly become an interesting area with things like Vivity, where you actually get a lot more, even if you have mild amount of anisometropia. I always do the distance eye first, because then I can demonstrate what the other eye would look like by doing a trial of near ads to show you what the contralateral will achieve. There are, of course, we talked about monovision for distance, and you can put an EDOF on the contralateral side. I'm not a mix and match kind of person because, again, I think I'm unable to explain the complexity to the patient. And of course, we are lucky enough to offer the ability to reverse it if you need LASIK. This is a comparison from the original trial where we had patients who happened to have an isometropia during this Vivity randomized clinical trial. This is the post-hoc analysis we presented. And for them, the unaided distance vision was hardly different in the two groups, where there was a half a diopter difference versus no difference. But the near visual acuity picked up a significant amount. With mini monovision, the logMAR was 0.14. The consequence of that was, with binocular distance visual acuity, distance targeted Vivity, only 26% was spectacle free for all tasks, whereas 53% became spectacle free for all tasks. Both had excellent distance performance, even if you had micro monovision. Intermediate was even better than Vivity for distance, and near task, of course, it was a vast, big improvement. And I think the future is going to be, even though the trifocals have done well, this future is heading towards less is more. Thank you very much.
Thank you, Bala. Clarifying this rather intriguing concept of monovision, and I really, value the comments from others who is practicing monovision. Is anybody here practicing monovision?
So, Dr. Bala, I had a question. This was a very interesting talk on monovision, something that, these days we are not attempting to do. I wanted to know your take on the role of, the use of astigmatism as an advantage of with the rule astigmatism, because I tend to use it off and on to promote a Sturm's conoid in the patient for range.
Yeah, this is an interesting one because the literature certainly doesn't, there are some publications that originally said yes, and then there are even the mathematical models didn't quite support it. And it is unusual and difficult for me to comment because we go hell for leather to correct any amount of astigmatism you have in Australia. You have 0.6, I'm definitely correcting. So using astigmatism for defocus, we are in the middle of that study, but we haven't finished it as such in our own hands. But yeah, it's interesting you brought that up. That's an excellent question.
So if I can
Naren, please.
Yes. So actually, in our hospital, we still do a few cases on monovision because, not all patients can afford these expensive lenses. And when they cannot afford and they're very motivated, we have a lot of patients who are very motivated. More than distance vision, they keep saying, I want to see near, I want to see near. So in such patients, monovision does fantastic. A little bit of counseling is there. Definitely you need chair time for monovision. But once they have accepted it, I mean, they will be the biggest brand ambassadors for you, because they're going to brag about it. They're going to brag about how much less money they spent, and they can still see near and far. I mean, they're really good ambassadors.
I think the micro monovision Dr. Bala alluded to in using VVT IOLs in particular is very interesting. And if you are on target, as you say, it has an appeal for those who really would like to depend less on the glasses. So I think monovision has its own place. In some parts of the world, it is not very popular, but there is an appeal, as Naren just now mentioned it, for in real world. So I think it's something we need to keep in mind and use it judiciously, depending upon the patient's response to counseling and the kind of IOL that you are planning with that, whether -0.5 or whatever Dr. Bala said. So any other comments? Otherwise, we move on to Naren's presentation. Okay, Naren, go ahead, please.
Just one sec. Can everyone see my screen?
Yeah, it's visible.
Thank you, sir. On this onset, I would like to thank Aios and Alcon for giving me this opportunity. So today, let's decode an unhappy 2020 patient. All right. So now all of us had cases where we have done a perfect surgery. The surgery's gone perfect well, and the lens implantation, everything was bang on the target. And the next day, when you see the patient, even before the patient talks, you will say, "No, don't worry, you're most welcome." And suddenly the patient looks at you in a very, explanatory this one, and then he says, "No, doctor, I still have a lot of glare, halos, and so on and so forth." Now, how do we turn these frowns into smiles? So one of the first thing is to prevent it. And all the speakers, Dr. Bala, Dr. Samresh, Dr. Sandeep, have wonderfully covered in detail. So I'll just go briefly touch on the topics. One is choosing the right patient. Now, how do we choose the right patient? We need certain basic equipments. First and foremost is a detailed slit lamp examination is very, very crucial to rule out any kind of abnormality. And once you've done that, you've won half the battle. So make sure you look at the tear film and also look at the pupil size. Photopic, keep a cutoff of 3 millimeters and a scotopic of 5 millimeters. Always look at angle alpha, keep it less than 0.6 millimeters. And in terms of biometry, always go for a optical biometry. It's especially when you're going for these premium lenses. And all of this, I'm talking about a trifocal lens specifically. And the other point is, let's say if you're not able to use the biometric, at least you have to use an immersion. Please do not use a contact method. Now, you need to assess the cornea also to look for any high order aberrations. We usually keep a cutoff of less than 0.5. And OCT or macular OCT is nowadays a must for any cataract surgery, not just a premium lens, because sometimes you can easily miss out, the subtle changes of epiretinal membrane, which when you do your regular fundus, you can somehow miss it. Yeah. Now, when we look at formulas, we have a lot of formulas in the market right now. But if you just ask me, can you just tell me one formula which works most of the time? I think simply just go with the Barrett's Universal 2 formula. Or if you can have hands on the TK formula, then that's fantastic, even better, which will work for most scenarios. Now, the 3 C's is extremely important. Counseling. You really need to sit with your patients, sit down and talk to them, make them to understand, and make sure they have more realistic expectations. One of the tricks when how I counsel my trifocal patient is basically what I say is these lenses have, really cutting edge technology. They have these rings around the rings on these lenses, because of which when you see the light, you see rings around. That means the lens is working really well. But over time, as the time goes, it becomes fader and fader. These few lines make us very, very, huge impact. And the patient post-surgery, when he sees these rings around the light, he's very happy. It'll not be a complaint. Oh, good, my lens is working. So he'll be happy. So these small tips, I feel you really need to talk to the patient And by doing so, the patient becomes more comfortable. The next thing is when you're counseling, you really understand what his needs, because a lot of patients, they say, okay, I want all distances, distance, intermediate, and near. And in such patients, trifocals do fantastic. And in certain patients are like not so particular about the near vision. Once in a while wearing glasses, they're okay with, but distance and intermediate, like computer or cooking, they're very particular. They don't want to wear glasses. That time EDOF lenses do really well. Now, after doing certain testing, there'll be scenarios where you have these borderline cases where, angle alpha is borderline or the high order aberration is borderline. In such scenarios, actually EDOF lenses do really well. And in terms of vivity, you can even push in certain retina abnormalities and other things also. It has really, opened up a lot of new opportunities for different patients and doctors. And definitely like this one, in terms of astigmatism, anything more than 0.5, please do not put a regular trifocal lenses. Always go for a toric one. This I mentioned in all my talks. In all my toric patients, I implant a CTR. As you can see, I'm implanting a CTR under irrigation. The trailing part of the CTR, I always hold it with a microforceps and implant it into the bag. That way, you're rest assured that it doesn't slip into the sulcus. Now, here you can see the intraoperative OCT of just an implanted lens. Now you can see a huge gap between the posterior capsule and the lens. This is one of the reasons why there's a higher chance of rotation during the early postoperative period. Now, when you implant a CTR, it expands the bag and brings the anterior posterior capsule closer together and increases the contact between the lens and the bag, thus preventing the early rotation, the rotation of the lens during the early postoperative period. Here you can see an image of the, post-implantation of the CTR. There's a beautiful contact between the posterior capsule and the lens. Other than just polishing the posterior capsule, please do not forget to polish the anterior capsule also in these premium lenses, because any kind of a fibrosis or, PCO can really significantly affect the visual quality in these kind of lenses. Always also align your toric lenses perfectly. If you have a markerless system, fantastic. It makes life so much more easier and much more accurate. So when you compare a marker versus markerless system, actually in terms of quantity, absolutely no difference. But when we look at the quality of vision, there is a significant difference, especially when you're going with a toric trifocal lens. And several studies have published this. Now let's go over a few cases. So here's a patient who had 20/20 vision for distance, intermediate, and near, but extremely annoyed with his vision. So when we look at the visual quality, there's something arising from the cornea or the surface of the eye. So we looked at the tear film. As you can see, there's a significant abnormality. So we put the patient on dry eye treatment, and this is how we improved. And automatically his quality of vision also improved fantastically. So now coming to the next case here, again, a post multifocal patient had a lot of glare and halos. And this is how his quality of vision was. It was pretty bad. And when we looked closer, actually there was decentration of the lens. Sometimes just a good slit lamp examination itself can pick up so many things. And whenever you do face some problems, do not try to blame on something else. Always start with the basics and then keep going ahead with your investigation. Now, here's one more patient who post-surgery had a lot of issues in terms of visual quality. Basically, the patient had posterior capsular opacification. The early PCO also can disturb these trifocal lenses. So do not shy away from doing a YAG. It will improve significantly. The visual quality will improve significantly. But with the current generation of lenses, the chances of PCO are extremely rare. So here's the last patient. Basically, it's again post-trifocal lens. Patient's really unhappy. And when you look closer, basically patient is left out with the residual astigmatism. So what happened here? How did we miss this? So what happened is the doctor ordered a trifocal toric lens, but the company by mistake sent a regular trifocal lens. and the doctor did not check it. So it is very important to, even though if you have ordered it personally for that patient, always check the lens, not just once. You need to have 3 or 4 times, multiple checkpoints before you implant lens, not just trifocal, any monofocal lens also. Make sure you have multiple checkpoints before you implant lens. So to summarize, how do we prevent a 20/20 unhappy patient is, first is always make sure you choose the right patient. Counseling is very, very important. If you, if I put an unhappy patient into an equation, unhappiness is equal to expectation divided by reality. If the patient's expectation is more realistic, no matter what the outcome is, you're rest assured the patient will be happy. Avoid extremely demanding patients. Always have a closer look for any abnormality. And a good practice does not just mean having a lot of patients. You need to have a lot of patients too. Whenever you do face any issue, please don't be impulsive. Always sit back, analyze the situation, come to a diagnosis and then think of a solution. Lastly, I like to say, always keep your happy patients close, but your unhappy patients closer. Make sure you see your unhappy patients more often, and you need to reassure him that you will be with him till the time he is happy. Thank you for your time.
Thank you, Naren. Very useful tips. And I think we learned from the first presentation on the diagnostics and yours that the preoperative workup remains very pivotal in this whole entire process. And as Samresh mentioned, a separate devoted time for preoperative work with the regular technicians and a consultant doing only that kind of job and not general OPD would be something which would be very valuable. I also find that having a questionnaire, survey kind of questionnaire, and Alcon has that survey, but you can have your own survey and modify that, also will allow you to assess, but don't go verbatim from the survey and you have to ask this, have you written this, but actually tell us in your priority, if you have to select, which one will you select? Because I can't cater everything in it. You are asking stars and moons. So you need to use this question survey, which is very good, but use it judiciously from each patient, and then decide what kind of strategy that you need. So I think, Naren, you brought out very, very important points in this process. So anyone having any comments and questions? Sandeep, let's start with you.
So you're muted.
I think it was a very useful morning, well spent. We have learned a lot from each other, and there is a definite role for both the trifocal and the vivity to exist together. There are those patients who will demand good reading vision without glasses, so we definitely choose the trifocal for them. But I see an ever expanding role for the vivity in my practice, and if really, and I think it's said again and again, if cost were not a consideration, I think the vivity should replace probably all monofocals going forward. But Alcon seems to turn a deaf ear to these things. They make billions of dollars on this, but I don't know. I don't know what you have to say about it.
No, I think I repeated n number of times on the wall, and I'm hitting my head on the wall. So I think we have made it very clear, abundantly clear, more than one occasion. But I think, having said that, word and as Naren said, expectations and reality, and the expectations goes up proportionate in many situations, not on all, as proportionate to the money they spend. But I have one happy patient where, happy in the sense that he was a real word. I had a patient with a very advanced blackish cataract. He lost to the follow-up for 10 years in the present set for the cataract surgery. And I told him that I don't know the back of the eye function. You may not benefit, but if you have a potential function, VVT is a good lens. And he agreed to pay for VVT. He was not a very rich man, but he valued his eye. And unfortunately, he didn't improve at all because he had some kind of a vein occlusion or something. And he was a bit disappointed, but he accepted that because we had counseled them. More than one person in our team counseled them that you're paying for this with the hope that you will have vision, but we really don't know. And he said, yes, doctor, you will tell me, but I hope that I have some vision. So this is what you, Naren, said, expectation and reality match. And that's where any help given to us from the manufacturers of all kinds, not only necessarily Alcon, some companies do better than Alcon, but any help in bringing their expectation down, a counseling tool that we are looking forward to hear from Saurav, but also the pricing stuff, because at the end of the day, what matters is the hard way on money. It's not Australia where they pay nothing. Therefore, you see everybody putting whatever. And even if it works like monofocal, they will accept because who cares? They never had to pay anything extra than mono or anything, whatever. So I think that customization and companies teach us to customize for the patient. I told this to the very high officers very recently in the meeting that I was involved, that the industry talks and teaches us to customize and make for you IOL and so on, but do they customize for each market? Do they customize for each KOL and practitioner? No. And they now expect us to customize with all that. So I think we have one speaker here, Alcon, and the other one handling. Please take this back and report it not only to your highest officer, but to the regional and international. Don't wait. You will not be sacked from your job. And if you're sacked, I will fight and employ a lawyer for you. Don't worry. But do that, please.
Sure.
Right? Okay. So I think, Saurav, I know you have helped all of us and many more, I know. And you and some of your team members and Alcon in general is very passionate about educating us and the patients. And we are looking forward for your Peeps and pearls. Yeah, please. Go ahead, sir.
Just let me know if you can see my screen, sir.
Yes, we can hear you now.
Perfectly fine. So hello, everybody. And at the onset, I would like to thank AIOC for giving me the opportunity, especially putting a non-clinical topic in this agenda, and that's so very important. As they say, the proof of the pudding is in eating. And so the whole idea about this is no matter what technology is, how quickly you're able to adapt to your practice. And that's the whole idea. And this particular topic that I have for the next 15 minutes, I'm going to share some best practices that I've learned from others, and how you can quickly integrate a presbyopic correcting lens in your practice. So with that, let me quickly get started with a couple of stats that, that were eye-openers for us when we did this survey. So by the way, the adoption of PC IOLs in a PEC region per se is the lowest among all. Leave aside Australia, as Dr. Vasavada rightly said, of course, the paying methodology is different. It's not as it's India. So both for toric and for PC IOLs, the adoption in the APAC countries, which includes India, are very less. And with a survey that we did just 2 years back, not very long back, it was a double-blinded patient survey with a very proper team that we did. We found out that only 8.5% eligible patients received this advanced technology, and 82% of them were actually interested in any one of the advanced treatment. When we dig further on it, we realized that out of this 8.5% who received this technology, and we checked the others, 94% would actually pay additional money for that. But that was something that was a loss for both the patient and the practice for sure. Now you would say that that's epic, but what about India? And in India also, the survey came down that 7 out of 10 patients say that they are at least ready to pay minimum for 50,000 rupees for a regular cataract procedure. And the saddest part was, and when we found out from this survey, that only 2 out of 10 patients were actually offered any premium lenses. And that's where the whole problem is. And that's why it's super important that we address that there is a huge gap that exists, which we need to understand that, versus what patients want and what as practitioners, practitioners offer to the patient for various reasons. And before we get started, and the biggest thing that I figured out that, is when you're, and this presentation especially will be very useful for people who are not yet figured out, who is on the way of, integrating this particular technology. And they must be probably battling or getting influenced with one of these thoughts. And I'll just read out, when it comes to multifocality or PCIL practice, they say, probably many would be thinking that if and when patient asks for a particular presbyopic correction, I'll offer. Why do I have to proactively offer them? The second would be probably that I cannot give additional chair time just for the sake of promoting a package. And then the third one would be, let's say, only affluent, and this is a misunderstanding, only affluent classes of patient would be interested in a multifocal treatment. I don't think so. This guy is right for a multifocal patient. And lastly, which is the most commonest that we found out, is that if I offer a PCIL package to a patient, the rehearing at the price, the patient might just flee and might just lose upon the regular surgical patient as well. So let me play it safe. So these are some of the things which becomes a big inhibitor when you are in the journey of integrating PCILs in your practice. So with that, let me just share some top couple of best practices that you would want to consider when you're integrating this into practice. The first happens to be, let your patients know there are enough and more opportunities in your practice, not just the waiting launch, where you can make sure that the patients know about this particular technology per se, right from the reception to the time he checks out, for that matter. And every point in time, there are certain ways. It doesn't have to be just a poster and literature, but that with several ways that you can communicate that there's a technology that exists and you can probably be a beneficiary of this particular technology. And I want to specifically bring your attention to a particular patient journey that you would consider. A patient journey passes through this stage, where he is from the pre-consultation, the complete referrals to the pre-surgery, surgery, and until he becomes an advocate. And the education happens much before the diagnosis happens, before the consultation happens. And that's where it's super important that we realize that, any amount of education that we give. So ideal scenario would be that you would want a patient who would come to you knowing for whom you don't have to start what is cataract kind of a thing. A patient who already knows certain, and he has a list of questions to ask you. And this is where this is important, and where I wish Dr. Bala would have been here and he would have shared more insights on this, is the fact that all the other countries have this very important culture where they send pre-read materials, to their patients before the consultation. This is nothing but, set of PDFs or videos that is sent over WhatsApp or any other, or on mail for that matter, where the patient is expected to read and come with that questions. Now, it may not be that, it may be a situation the patients might not read completely, fair enough. But at least even if they would read something, and they would come, life would become much more easier for you. And that's why ideally, and when I was in one of the meetings when we were discussing with Dr. Michael Lawless, and he says that he actually sends a customized video to the patient. And the ideal scenario would be where the patient actually comes in, and that's what happens in other countries, where the patient comes in. So I went through this material and I have a couple of questions on the multifocal. What is functional vision, functional near vision all about, and so on and so forth. And that's something that together we should start. And it's very easily, it's just about putting it into your system. So before I move to the next point, it's very important for all of us to not undermine the needs of spectacle independence from many patients. And there are, we were astounded with the fact that, there were so many instances that we've come that patients, for very smallest of the reason, wants to get, rid of spectacles. It could be as simple as that the nose marks is not good enough. I was hearing from one of the surgeons sometime back where he said one of his patients wanted to get rid of his spectacles because he was an avid rummy cards player. And he said that, whenever he had these cards, your opponent would cheat with him because he could see the reflection on the spectacles. A dance teacher doesn't want to wear it because, when she sweats, it falls down. There could be different reasons why patients want to get rid of spectacles. So just judging them is not a great idea. The most important thing that Dr. Vasavada just mentioned is having and using the lifestyle questionnaire. Now, this is a simple questionnaire as you can develop it yourself, but there has to be, it's not about the tick in the box, just that you can see. This is the moment where patient starts thinking that what probably he or she will be able to do with spectacle independence or the reduced dependency on spectacles. Oh, really, I can do this, I can do that. And when this becomes a living document for the entire patient journey, for the entire, for everybody to pick up. And you can pick up the conversation saying that, you just said that you want to get rid of spectacles because of this. Just imagine how well your life will be when you swim without this, and so on and so forth. So this is something, happy to share any of these documents that, that any of them wanted, but you can develop anything, any of these questionnaires by your own. But this is super important. I think I'll not spend a lot of time over here. All the speakers spend enough amount of time discussing that there's no replacement of surgeon chair time. Chair time is something that is absolutely indispensable at this point in time. If especially it's a newer technology, the onus lies on your shoulder before your staff takes it over. But that amount of chair time is the investment that you're making. But just to add, additional to the chair time that you get, what's really important is to make that handsome recommendation. What's the meaning of a recommendation over here is, towards the end of the conversation, you say that this is what I would recommend. Now, most of the places patient practices hate to recommend in the fear of assuming that, they might sound as if they're selling or they're sounding pushy about it. So here's an example that I often give. There are different ways where, you can recommend. And I have seen a lot of successful practitioners using one of these techniques when they have their own style of recommending. And I'll just read it out verbatim the way it is. It says that one of the patients would say that whatever you decide, sir, aapke upar chhod de, sir, aap bataiye, sir, kaun sa lens lagana chahiye. And there are two ways where you can answer this particular question. One is a simple to say that aap decide kijiye, whatever you choose, me and my team will do the best, rest assured. The other way of doing it, and if it's a patient, you would say that based on your visual needs that you just mentioned in the lifestyle questionnaire and your eagerness to be minimally dependent on glasses, I would recommend a panoptic lens for your eyes. However, whatever you choose, me and my team will do your best, rest assured about the patient part of it. And if it's a caregiver, you would say that, Mr. Das, based on your father's visual needs, had I been in your position, I would have opted for the Vivity lens for my dad. Nevertheless, whatever you choose, me and my team will do the best. And the patient might not necessarily walk away with the Vivity or Panoptics, but he will go or she will go away with a lot of clarity. And that's recommendation. And in no ways this will sound that you're pushing something or selling this to your patient. There are several documents. You can use a paper, a scribbling paper, and we can also share with you a couple of recommendation pads, that you can use to scribble around so that it becomes visually more engaging for the patients to understand and the caregivers to understand. As Dr. Sabresh also mentioned, about the counseling part of it, a lot of information can get lost in the translation. And obviously, you as practitioner cannot give n amount of time for your patients. And that's why the role of counselors is super critical, super important at any stage. The counselor should be groomed on both the things, not just about the communication part, but also the technology. They should be aware that whatever they're talking about is worth it, and then that'll come in their voice. Several tools are available with us and several of the companies which they can use, presentation, simulation apps, and so on and so forth. And keep your counselors motivated so that they can walk that extra mile to take the conversation forward. Now, what exactly do you communicate and how do you communicate? The benefit has been discussed at multiple places, that what should be, how do you define in one sentence, what is the advantage of a multifocal or a presbyopic correcting lens? And again, I'll read this out verbatim. These are several takes that I've picked from different practices, the way they communicate the value of a particular, of the presbyopic correcting lens in one liner. One of them would say that with the implant of this lens, you'll find that for more than 90% of your daily activities, you'll not need spectacles. Others would say that, if you walked out of your home only to realize that you've missed carrying your spectacles, then even without your spectacles, you'll be able to manage the work and you need not worry. Others would say that multifocal lenses are designed for active lifestyle, active individuals like you. And most of my patients who have received this technology, they feel that this lens has complemented their lifestyle. And lastly, you could also use saying that with the advent of the new technologies, we can help you lower your dependency on glasses for near, intermediate, and distance. And you're lucky. And that's the compliment that not all are fit for this lens. You are fit for this technology. If you had come to me a few years back, I wouldn't have been able to offer you this particular lens. So you can use many of these lines. Again, you're not promising 100% independence of glasses, but yet you're communicating the benefit. Dr. Naresh just mentioned, that, how important it is that, to explain patients, and not to have that unhappy patients. And one of the factors that we realized is that when they see the halos, and just in case today's technology is obviously, far better. But just in case, it's a good idea just during the counseling session, you can show the simulated pictures, which is available with us, happy to share as well, which says that this is what is halos like, and this is what could be in the initial stages, and this is what it could be 6 months later, which means it's working normal. When they see it, they don't complain it. However, the most important thing that, we advise the counselors to say that, please tell as a reputation that, do not compare your eyes left before the unoperated eyes left. And that's the common mistake that patients do. And that's what leads them to unhappiness. I have 5 more minutes and I'll quickly wrap this up. So, and continuing to that, this is the card that you can use. I don't remember, as one of the speakers just said, how you can summarize the visual needs. And this is a surgery summary card where it's like a document. And I think Dr. Nagvik has said, this is a document that you can have, which says, that the parting document, which says that this is what we've agreed upon. This is the lens. And I'm saying these are the distance, that, we are trying to achieve, reduced dependency on glasses and so on and so forth. And that transferring happens. And when they read this document and they sign it, that's a large amount of clarity. One of the biggest ways to boost the growth of multifocal is to have your own patient, the word of mouth publicity. That's the biggest way. And developing your own patient testimonial tools. Dr. Samresh is over here, is a champ in this. Having your own, and there are several theories which talk about that. When you have your own organic, own patient testimonial tools, that becomes a very powerful organic growth for you. And it's very simple. The moment, they call it the moment of truth. You all realize many a times that have a patient who is really happy. You see that they've come for the first refraction. Doctor Sahab, bahut maza aa gaya. That's the moment that you really want to capture. You didn't need to do nothing else. You just need to assign a person with this mobile and who knows this and capture that moment. Slowly and gradually, you will realize, that you have a big set of, you have a big collection of videos, happy patient videos, which you can run at several places on your websites or on your OPDs or at several places. But the point is that, you miss out because by the time you're arranging, things are gone. The easy way is just assign a person, and it's very simple to do it, these days, but it's a habit that you can probably put into practice. And lastly, I think it's important that, you develop patients, whatever patients of multifocals or PCLs that you're developing, you develop them into ambassadors, and that's how the practice multiplies. That's how the adoption multiplies. And that's why it's important to create that wow factor in the patients. And how do we do that is by a post-operative discussion. After the surgery is done, it's important to make them feel happy about it. They may be clinically happy, as Dr. Naresh said, but many times they're not emotionally happy, and which is where the wow factor is missing. But why does that happen? Because the patients feel that probably this is how everybody sees. What's a great deal if I put a VVT lens or put in 90,000? But when you make them do a couple of activities, like for example, this particular activity wherein it's a pre-operative reading test that you do. You make the patient read until at a particular font size, take their signatures, and after the surgery is done, you pull out that conversation, pull out that paper and say that abhi aap kahan tak padh pa rahe? And he says that 6 points. Did you see that, sir? With this particular lens, I've reached from here to here. And then he becomes wow, he becomes happy, and that is where he goes and tells everybody that what, you should go to this practice, you should use this particular product, and so on and so forth. Lastly, don't underestimate the caregivers. The caregivers are the decision makers, in a practice. And whenever you talk about the dependency factor, that how your dad is going to be less dependent, your mom is going to be less dependent, it really rings a bell, at many times. And a lot of practices have told me that this is what they use as a term when they converse. The very last slide is how do you price a package? And I learned this from Dr. Vasada several times, and Dr. Vasada often tells that never feel apologetic charging of appropriate fees for these particular products. You don't be ashamed of it. Whatever is the right fees, but you can just put it up in different fashions. For example, many places use this communication saying that we have packages from multifocal to monofocal lenses, the reverse order saying, encourage copay. There are several easy EMI options. You can tie up with banks. The problem happens is, where the patients, they have a set of mind that they probably want to pay 50, 60,000. They get convinced with the technology. Oh, wow, this is great. But that additional top-up money becomes a problem. If you tie up with banks, which gives them, easy EMIs or, flexi-pay kind of options, with these days, there are several available. Even that few percent of the interest, even if you were to absorb it, if you do your maths towards the end of the day, try it for 1 month, it will really be still worthwhile taking that particular plunge and getting into this kind of engagement. And lastly, I think nothing works best than conviction of the technology. And that's where the conferences and discussions like this are important. Just wishing is one thing, but you should reach to a stage from wish to commit where you feel that every clinically suitable patient should definitely opt for one of these lenses based on their lifestyle. And that conviction definitely happens with science. So To summarize, I think 3 things I would say: that inform your patients completely, recommend wholeheartedly, and try and build ambassadors. And that is what will see a greater integration and greater enhancement of PCL adoption in your practice. So thank you, Dr. Vasavada. Thank you, everybody.
Thank you so much. Thank you very much. We have 2 questions here from the chat box. Question from Dr. Vipul Arora. Can VVT be implanted in one-eyed patients? Naren, what's your take on it?
Definitely, sir. Definitely. I think, I mean, not just us, I think a lot of doctors have become so comfortable. I think they're almost replacing all their monofocal practices, monofocal lenses with these VVT lenses. I think definitely, why not?
No, but not in India. Okay, thank you.
Because of the
well,
cost.
I agree. No, I think I'm sure we all will agree that VVT implantation is not a contraindication for one-eyed person with no comorbidity, definitely, and with slight comorbidity, but a lot of counseling because they are going to pay from the pocket, unlike some other countries. But I agree, and I'm sure all will agree. There is another question from Dr. Pradeep Dindore, which is the best lens for a plastic surgeon and a general surgeon? Obviously, he has a patient, his friend, he is considering that. So each of you, please tell very briefly for a plastic surgeon and a general surgeon, you know. Sandeep, you are an expert on it. Tell us.
So I've done a few surgeries for people of other specialties, and you'd be surprised as to the uptake as far as presbyopia correcting lens is concerned. Trifocals were being used by me quite regularly. Now with the VVT having come in, I've been using the VVT. Now specifically for a plastic surgeon or a general surgeon, I think the VVT should be a great lens. If the plastic surgeon or general surgeon insists on reading without glasses, if everything fits into place, I would not probably hesitate to use a trifocal in them also.
Samresh?
Yeah, I mean, my choice as of now for a person who's doing surgery would be a PanOptics because it gives them the full range. But my experience with VVT is building up, and I would really love to see how it performs when I get the right patient to operate on for this.
Can I share one more experience here?
Yes, very briefly, yeah.
Okay, now this is an ophthalmic surgeon I operated on Thursday. He was about 52 years old and prior myopic, had LASIK done about 10 years ago for a -8. You know? So on Thursday, we operated him for his cataract and put a VVT inside. His vision the next day was 6/6 N6 partial. And you would be pleased to know that he had a full surgical list yesterday. He operated yesterday on Saturday. So this was just 2 days after surgery.
That speaks very high of your level of surgery, Sandeep.
No.
Not a lens is a side product. Okay, Naren?
So for
plastic surgeon and a surgeon, general surgeon.
Yeah, for a plastic or a general surgeon, still my way I'm going to look at a patient will be just like any other patient. I mean, if they suit depending on what they want, if it is general surgeon or a plastic surgeon, if he is very comfortable wearing glasses, then simply go with monofocal. But he's very motivated, he wants to get rid of it, then definitely would go for it. And Dr. Sandeep also said, we have implanted a lot on even ophthalmologists, general surgeons, I mean, a lot of doctors, and they are very, very happy with this lens, definitely.
Well, I think I agree with all of you, but I want to share, like Sandeep, 2 ophthalmologists, very big ophthalmologists from out of the state. One had a good amount of multifocal practice himself. He was doing in his patients, and he was motivated for multifocal. We warned him of the halos and limitations, and we put PanOptics, and he rang like somebody found 3 days later when he went back, and he said, I did this many surgeries, and I'm very happy. So I was very thrilled, but I also offered him, can I come and work with you, sir? If you're doing so many surgeries every day. But he was very happy. The other surgeon from Rajasthan had to go to Udaipur every alternate weekends and travel back in the evening. And we put a VVT lens, and he's very happy with whatever. But the point, as you, Naren, and others mentioned, is this. surgery is one aspect of your assessment, is professional requirement. But remember, the other requirements, like that other doctor had to drive at the night. Other one has to have a motorcycle as a hobby. He may have another hobby. So surgeon or whatever his profession is an important consideration, but we need to assess all these other aspects of his patient and personality and decide, and you guys have shown us and taught us how to do that. So I think that is well said. There is no other question from chat box, but I would value 2, 3, 4 lines comments from each of you before we end. Sandeep, you start. Whatever you want to say, the final pearl or a tip, whatever, to Alcon or to the attendee or to all of us. Very brief. We are almost at the dot time.
One comment I'd like to make about Shaurav's presentation. He spoke about, sending material over to patients before they come for primary consultation. I mean, that may work in advanced markets like Australia, where, medicine is considered just like a profession. I think here in India, it's a little different. If you start sending them pre-consultation, things about lenses, they're going to say this fellow is a commercial doctor and he's not going to land up. So I don't think that works very well in our situation. I mean, many of these inputs are some things which you have got from here, but you have to get and devise inputs for Indian conditions. The other thing is about the banks. Now, I have a simple request. If you are so keen that we should give, tie up with banks and give EMI options, I think Alcon should bear that interest. Why should the doctors who have, every day I'm selling lenses for you. I work for you. What do you do for me? I'm asking this question on an open forum. What do you say, sir?
Yes. Do you want to say something, or can you say something? Are you allowed to say whatever? You have to respond to this directed question. One of you, please.
No, so thank you. I think the first part of it that you just said about the pre-read material. So I think what really, sir, is it is not about it's a general education. We are not allowed to use the brand. So I think it's just the education material, that we are trying to send, and that doesn't sell. That doesn't look very. That doesn't look that you're, it's very commercial kind of a thing.
The patient doesn't even know that he's got a cataract.
No. Let's be brief. No.
We can't hear you, sir.
Saurav, can we remind you of the question that Sandeep asked you? Instead of a bank, why don't you help us? What is the answer to that?
Well, no comments on that. I really can't comment on that.
Okay. All right. That's not a very good news, actually. I must say that.
We can show you the maths that I can show you the maths that it really works out, even if there's a small interest component, but no comments, why we should be absorbing it, but we can help the other ways.
No, because that's not a very nice way, I must say. You think about it and go home, because this is a question which is very pertinent in the modern times, because we are partnering, as you say, all the time. So the one partner doesn't keep working all the time. Other partner also has to contribute that. So I think it's a very valid question, and I thank and I support that question. Right? You need to come up, think about it as a team, and give some meaningful suggestion. So I must tell you this.
Sure.
Okay. Now, any other final comments from Samresh and Naren? Please be brief. We are overstepping.
I just want to say to the audience who's listening that please, the timing is right, and please adopt newer technology IOLs, because it's very forgiving and the outcomes are very, very favorable. And look at the patient as a whole, and not just the patient for revenue generation, but how to enhance the lifestyle of the patient by doing that skillful surgery and putting the right lens in the eye.
Yeah, thank you. Naren?
I would like to echo, Samresh, Dr. Samresh. Please, whoever's seeing this, talk or webinar, it is not at all complicated. Implanting a trifocal lens is super, super, super easy. and you get help everywhere. Just one call, you can just be simply guided, and there's not much of investment. See, in refractive surgery, there's a lot of investment that you have to do, but in these kind of cases, or phakic IOLs, all these lens options, there's no investment, but you can become a refractive surgeon. So I would say this is the right time. Please do not shy away. It is very easy. Don't listen to anyone that it's very complicated. It is easy and doable. All the very best.
Thank you. I think if I have to summarize, I think let us as a person holistically, and also the scientific data that we are collecting in a most precise way to formulate a strategy along with the patients after discussion, whatever. That I think has never been as important as it is today. The good news is that the PanOptics and Vivity lenses really deliver what as a science or optical performance as well as we would expect them to do that. So that's another good news, that both of these lenses really perform well, optically speaking, provided you are precise in your calculations and target refraction, provided you take care of all the comorbidity and other issues from the eye, from the patients and other diseases they have, you are very likely to succeed. So that's saying, and counseling is very important because they should be realistic. But I agree entirely with Sandeep, and all of you have indicated that, remember, you are the one who is facing the patient. You as a hospital institution or individual clinician, and it is you and the patient interaction interface that is going to go this way or that way. So the sole responsibility, moral, legal, ethical, and social is yours. Whatever the other marketing strategies you have as an option. So keep your integrity and honesty and ethical practice, and everything else will fall in automatically. Do not chase this brochures or whatever this marketing material is. Keep in mind and use it very, very sparingly and judiciously, as it was pointed out earlier. So with all that thing, I think the time is very good, and the future is even brighter for us with these two wonderful IOLs that we have for our patients. So if there's no other questions or comments, I would like to end this one. And I thank Dr. Namrata Sharma and Rajesh Sinha for allowing us to conduct this. They could not join us for the connectivity issues, and All India Ophthalmic Society and an Alcon for their support. So thank you all very much, and have a happy Sunday. Thank you.